The infertility journey should be fairly simple. The most important thing that couples should ask themselves is, do I have a problem or not? Most couples will actually be pregnant within the first 6 months of trying. In fact, about 72% of all couples should be pregnant within the first 6 months. Even though we traditionally define infertility as 1 year of unprotected intercourse with no pregnancy, a red flag should go up after 6 months. I think it's very important for couples to realize that. Once a problem is suspected, then the first steps are to see a physician, to do some simple testing to determine what the cause is.
Okay, well, let's take a typical patient. They're both 25. They've tried for a year, good health, and nothing's happened. The first person they should see is their gynecologist. Their gynecologist can do basic tests. They can test the woman's FSH to see whether her eggs are okay, which they probably are, a sperm count on the husband, even order a radiologist to do a hysterosalpingogram, although I like to do my own hysterosalpingograms. It can be done by a radiologist. And then even treat the patient with something like clomiphene for up to four cycles. If that's not successful, then they should be referred to a reproductive endocrinologist who does infertility, or someone who not limits their practice to infertility but does a majority of infertility in their practice.
Whoever does the test should be familiar with how to interpret the results in the context of treatments that are available. So whoever you see somebody who has experience in the area. Once those 3 tests are done, the first question is, well, what's the best treatment for me? Well, of course, that depends on what the problem is. I would break treatments down into 3 main categories. The first one is clomiphene pills that the woman would take, combined with intrauterine insemination treatments. And that treatment is used for many different causes of infertility. If that were to fail, the next level of treatment is the so-called gonadotropins, or hormone FSH, which are injectable medications, again in combination with intrauterine inseminations. And the third level of treatment would be in vitro fertilization. Which treatment one chooses should be determined by a discussion with your physician, because you don't necessarily do the simplest thing. If, for example, there is a tubal problem, you'd want to go directly to in vitro. On the other hand, you wouldn't want to do in vitro fertilization too quickly. You want to give simpler treatments a chance to work, and because what you want to do is help nature do it without being overly aggressive. So that's the balancing act, and that's where the judgment comes in, and that's where it is, I think, very important to speak to somebody who has experience in dealing with these problems.
Well, I think that when you're looking to go to an infertility specialist, the place that you shouldn't look is the yellow pages in the telephone book. Because a lot of physicians list themselves as infertility specialists or even reproductive endocrinologists. But the key word really is reproductive endocrinologist that's board certified, meaning they've had the 2 extra years of fellowship training. And they are the most highly specialized and usually don't do obstetrics, but actually just follow you very early into your pregnancy and then send you back to your OBGYN. So being really clear on what a specialist is the first step. And then certainly making sure that it feels comfortable in the environment and that you're comfortable with the physician and that you feel the team is there for you.
In the big cities in America, it's easy to find reputable reproductive endocrinologists. American Society for Reproductive Medicine keeps a referral sheet. The American Infertility Association keeps a referral sheet. Resolve keeps a referral sheet. And these people have been scrutinized, at least that they're credible.
Organizations like the American Fertility Association are not watchdog organizations. You know, we like to say we refer, we don't recommend. And we live in a very litigious society. So we all have to be careful about the information that we give out. But you can know that if you come to us and the doctor is on our referral list, that they have certain qualifications to have been on our referral list. No one gives money to be on a referral list. They just have to be able to answer correctly our 6-page questionnaire, and so we know that they're reputable. We like to refer to centers who report to SAR, the Society of Assisted Reproductive Technology, and who give their results to the CDC as they're required to do by law.
The next thing that they should look for are success rates, and they should look for success rates in their category. So if somebody has an 80% success rate in women that are 25, and the program and has 2% success rate in women 40, and you're 40, the 80% is insignificant. In fact, it's deceiving.
Because remember, if I'm 37, my outcome is different than somebody who's 28 or who's 43, and how does my center stack up against others in the same age range? That's available through the CDC.
IVF statistics don't tell the whole story about an IVF center and cannot be used to compare IVF programs. The reason for this is that some IVF centers may have lower statistics if they treat more difficult patients. Also, placing more embryos in the uterus will increase an IVF center's success, but will result in an unacceptably high likelihood of multiple pregnancies. There are too many factors that can account for differences in pregnancy rates amongst IVF centers, and these differences are not apparent from available published data. Be cautious when interpreting or comparing IVF success rates amongst the different IVF centers.
I think it's important to be with a practice that has reasonable hours so that you can go in for your blood tests early in the morning, that they're open on weekends, that you won't in holidays. Those are important questions because you don't want to miss a treatment because, oh, I'm sorry, we were closed for the 3-day weekend.
The problem, of course, comes if you live in a small town, Bemidji, Minnesota, for instance. There, you have to go to the generalist, and your generalist has to do some basic test, and you might have to travel to the big city in order to get big city treatment. And it's not unusual even for here, where people have to travel 2 hours to get to the office, that we'll co-manage patients with a generalist, see them here once, come up with a plan, and then of management, and then take it from there. So these things can be done that way. I mean, the web, the internet has changed all this. I mean, you email somebody, they could do the ultrasound and email their follicles to me each day in order to see how the patient's doing. So there are ways to get around it, but you shouldn't waste a lot of time before you get to see the specialist.
Because infertility treatment is such an art and not a science, and because we don't know the answers to so much, and because treatment failure rates are so high, even though the doctors say their success rates are high, when you look at IVF success rate of 30%, it's a failure rate of 70% for the couple who's mortgaged their home. So I think it's really important that patients feel comfortable getting second opinions. And I've been struck by how cautious patients are. They don't want to upset their physician, and they may really like their physician, or they may not like their physician and don't want to get a second opinion because they feel like they may be punished subtly for it. So I think it's really important to normalize that and say it's really common to get second opinions.
Now, you have to give doctor number one a fair shot. But somebody goes through 2 cycles of IVF with one doctor and they switch to another. Are they successful? That would be interesting to know, and it'd be interesting to know what that other the other program did to help that patient, because there are patients that do well in one program and not in another.
I think it's really important that patients self-educate. It gives them a certain amount of a knowledge base to come in to a center. I think knowing the questions to ask, the really basic questions to ask, like, are you open every day? Or is my cycle going to have to go around your vacation schedule? Do you do an IUI on a Sunday if my body's ready to have an IUI? So I think, knowing those basic questions and answers are really important, and remembering that, again, that you don't have to know how to do the laparoscopy to be a well-educated patient. We don't expect you to be the doctors or the nurses, but you should know what to expect from a good center and what a good center has to offer. And that information is available to patients who are looking for it through patient organizations such as the American Fertility Association.
We have at Resolve a series of questions to ask if you're picking a specialist, and you know, people can access that on our website. That publication helps you, you know, kind of assess, like, are all these criteria being met?
You know, one of the issues that I've been having where I work at Boston IVF is how to inform patients of the services that are available to them, not the medical services, but either the mind, body, or social work services. And the problem is so many patients see it as punitive. Like, they'll be seeing their physician and they'll start crying, and the physician will go, oh, call Allie Domar. And you know, that's his think, okay, you know what, I'm not equipped to handle how upset you are, but she is, or the social workers are, or whatever. It's not punitive. I mean, infertility is extraordinarily difficult. And because we now have so much data showing that being really upset may actually decrease how effective the treatment is, I would like to see people being proactive. I mean, you know, it's not a coincidence that programs around the country are now integrating a mind-body center into their infertility treatment program. It's not a coincidence that most infertility programs have a mental health professional on site and on staff to work with patients. The problem is that you only see, these professionals tend to only see patients who've hit bottom. They're the ones who really just fall apart. And that's not good medicine. Good medicine, and if you ask for my ideals, everybody starting infertility treatment would be introduced to the concept. And in fact, at Boston IVF, that's what we're doing now. Every new patient gets a card, which they have to hand in, which describes all the different support services available to them. Because you know what? Don't wait till you hit bottom. I mean, be proactive. I mean, if you look at this big federal grant I got, we recruited patients before they got upset, and we could keep them from getting upset. That's very powerful. I don't want to see people hit bottom before they get help.
I think the worst thing to do is to deny the fact that there is a problem and just hope that it will get better with time.
Because you don't want to be haunted by the what ifs and if onlys years later.
It's actually amazing how many people don't seek help when they're trying to have a baby. And I don't really know why so many people don't seek help. Is it because of shame? I think shame is a really big issue. I also think that because of all the media attention around fertility treatments, there may be concerns that the children are unhealthy, and they are.
I think that certainly as a society we've expanded our idea of what family is, and that's opened the doors for people to build their families the way they want to. Whether it's a single mom by choice who chooses donor insemination, or a couple who chooses adoption, or uses donor egg with gestational carrier. I mean, it doesn't really seem to have a societal stamp of approval or disapproval anymore of how a family is made. I think we have evolved and are truly evolving toward understanding that a family is made up of people who love each other, care about each other, support each other, nurture, and grow together.